about 2.5 years ago, no, it was about 2 years ago, I get a message from a friend. She's in Chicago, going to the Academy of Operative Dentistry. And all of a sudden, she says, Davey, you have a lot of enemies around the world in dentistry. Now, at this time, I'm just fixing some patient's tooth. I can't remember who was in the chair. I can't remember what exactly I was doing. And the whole thing I was thinking about is, what did I do to piss somebody off so bad that all of a sudden my cases are being posted at the biggest restorative conference in the United States? Now, after a while of just asking my friend, what are they talking about? What's going on? And it came down to the idea of how the Allemans treat cracks is over treatment. Now, I completely disagree with this person's conclusions. I respect him as a researcher, but unfortunately, unless you have a patient come into your office and say, my tooth feels weak, like this patient did who traveled in from another state, and you look at the x-ray and the x-ray looks fine, you quickly look in the mouth, all the restorations look quite gorgeous, but as you analyze this lower molar, all of a sudden your heart just drops because all of a sudden you understand why this patient's tooth doesn't feel like a natural tooth.
Can't bite on it.
She can't bite on it without pain. She just can't trust chewing on this side. And as you look closer, it's very easy to see the problem. We have a clinical failure that is manifesting with a fracture through this Emax restoration that was bonded perfectly. The caries was treated perfectly. The only problem is that it wasn't connecting the tooth side to side, front to back, and top to bottom. Now, as I dissect the crack in the restoration, not only is the fracture in the ceramic, but it's also in the tooth itself. And this fracture is not a small crack, but rather a very large fracture that is propagating distal to mesial. So as I'm trying to figure out what exactly happened, because this was not a bonding problem. This was not a caries problem. This was what I believe a crack that was bonded over.
That did not stabilize it. You cannot bridge a crack. Let me repeat that. You cannot bridge a crack. No science shows you can bridge a crack. Teeth are extracted every day because cracks are not managed. Implants is the solution? Well, a better solution is to treat the crack when it's small.
Now, our approach with cracked teeth really relies on this principle that the intact tooth is the guide to reconstruction. Now, the intact tooth is free of gaps and cracks, and it's very resistant to fracture. And so when we say the tooth is connected side to side, front to back, and top to bottom with our biomimetic reconstruction, we truly believe it.
This is an advanced audience, Davey. A lot of these docs have been trained. Many of them heard many of our lectures. But the idea of differentiating enamel from dentin is the foundation of the biomimetic approach in the 6 lessons, because cracks in enamel are a stress relieving system in the tooth. It's a fail-safe system. So you're going to have cracks in enamel. That's what it's supposed to do. But when they pass the DEJ, that's when symptoms tell you you've got a bigger problem of infection that could kill the pulp and fracture the tooth in a way that couldn't be restored.
Now, most of the teeth that we have deal with a fatigue fracture, but also as soon as we understand that an intact tooth takes 500 pounds for a complete catastrophic failure and an isthmus that is 1.5, we lose 40% of its fracture toughness. So it goes from 500 down to 300. And if we expanded the thickness of your fingernail, which is roughly a 0.5 millimeter or 500 microns, then the tooth starts to behave completely different. Now, the most common treatment of teeth that are experiencing consistent pain on biting is full coverage crowns. And this paper, which was a 6-year evaluation, showed that 20% of cracked teeth with reversible pulpitis resulted in root canals after 6 months. Now, this case was that I treated, started to have spontaneous pain. We referred it to the endodontist. They did the endo through the PFM crown, and I asked the patient, well, we can repair this. The PFM looks fine on the x-ray, but I do believe that there's probably something else that's going on that caused the nerve to die. Now, as we stained with caries detecting dye, there was very minimal decay. If you're not looking careful and close enough, you would miss this vertical fracture that was probably affiliated with an amalgam at some point. And it eventually propagated and allowed the nerve to be infected and ultimately necrose.
Let's point out an important basic protocol in a biomimetic approach. In the 6 lessons, we teach that you have to have 6 to 8 magnification minimum. If you don't have 6 power, you're not going to be able to see these early cracks, these small cracks. So you have to have 6 or greater magnification. Now, what you're seeing in this slide is based on engineering science. Engineers have been studying cracks for over 150 years. They know what they're talking about.
Now, we really appreciate Dr. Andy Nelson giving us permission to use this case in this presentation. He practices in Massachusetts, but before he got trained, he understood that, I want to start dissecting cracks and then, reinforcing it with adhesive techniques and biomimetic techniques.
Nice onlays.
A nice onlay.
He had a lot of good ideas, but until he was trained by masters, he did not know what to do with cracks.
And so after 6 months, the patient started to become symptomatic. And unfortunately, there was a J lesion. The tooth had to be extracted, but it gave him a chance to
Look at
the tooth and analyze what exactly went down. Was this something that I made a mistake on? Or perhaps this fracture was, too far gone. Now, when he did 3 millimeter crack dissection, he went about 5 millimeters after his occlusal reduction. That was his level of comfort at that time. Now, he didn't know if that fracture was stopping or if it was continuing down the route.
Yeah, he crossed his fingers and hoped it could be bridged and stabilized. Failed.
But as he extracted the tooth, he realized that he could actually go a lot deeper without exposing the pulp and without going into the periodontium. But it takes that practice, that expertise in understanding the power of the peripheral seal zone in order to dissect. And if you go 9 millimeters in this case, and you still see that fracture being very, very deep, and the tooth goes non-vital or the tooth is lost, guess what? It was probably highly infected or perhaps, non-restorable.
But in those situations, you do the root canal, you tell the patient you have a limited prognosis, but we are seeing teeth like this, even with endodontic treatment, going 10 years, even when they have a fracture that is at mid-root when we treat them.
Now, when we go to the bottom of the fracture, we change how the tooth is now being connected. In other words, if we have residual fractures in the peripheral seal zone, but we disrupt it in the peripheral seal, then that gives the tooth a better chance to heal and also to resist a catastrophic failure. Now, this was not the idea of my dad.
No, I talked to engineers because I had a friend who was an engineer, and he gave me books to read. And all of a sudden, I found out that when you're repairing carbon, fiber, and composite parts of billion-dollar jet fighters or spy planes, you never let a crack not get treated. You always observe it and then you treat it as soon as you can. For example, an airplane wing. If it has a 3-inch crack, it still can be flown back to its home base because it takes 7 millimeters before the wing falls off.
7 inches.
7 inches, that's right. 7-inch crack on your airplane grounds you're dead. But a 3-inch crack grounds the airplane, but a 1-inch crack doesn't, because it can be repaired and you can still fly without those micro movements taking the wing off. But all of these ideas, when you talk to engineers, and I'd recommend all of you, talk to any engineer that's in your practice, talk about cracks, get some books, read them. You will understand that this is the science.
So we're not taking a dental approach to treating fractured teeth.
Because
We're-
dentists have never figured this out.
We're taking an approach that has been long advocated by engineers.
Right.
And in the abstract of this paper that talked about fixing
Rigs,
uh,
oil rigs in the
Gulf of America, it says crack removal has the purpose of stopping crack propagation and prevent future crack reinitiation.